If you only master one organ system before your boards, make it this one. The gastrointestinal tract is the single most heavily tested system across USMLE, MRCP, PLAB, FMGE, and AMC. And that's because it sits at the perfect intersection of pathology, microbiology, and pharmacology. Nowhere else in medicine do structural disease, infectious agents, and drug mechanisms overlap so tightly. A single mutation in a colon crypt cell can take 20 years to become cancer. A single enzyme made by a bacterium can decide whether your patient gets a triple drug regimen or a transplant workup. A single receptor on a parietal cell can be the difference between a healed ulcer and a perforated one. In the next several minutes, we're going to walk the entire GI tract, esophagus to rectum, plus the liver, gallbladder, and pancreas, and build the kind of integrated mechanism-first understanding that turns memorized facts into instantly recognizable exam vignettes. This isn't a list of trivia. This is the blueprint examiners actually write questions from. Let's get into it. Here's the master key to every high-yield GI topic. Disease, bug, and drug are never separate stories. They're one story told three ways. Take Helicobacter pylori. As a microbiology fact, it's a gram-negative organism that produces the enzyme urease. As a pathology fact, that urease neutralizes stomach acid locally, allowing chronic inflammation and eventually ulceration of the gastric mucosa. As a pharmacology fact, that same mechanism is exactly why eradication requires a very specific combination: a proton pump inhibitor to suppress acid, plus 2 antibiotics to kill the organism in an environment it has chemically rigged in its own favor. Once you see this pattern, you stop memorizing 3 separate flashcards and start understanding one continuous mechanism. This same triad logic applies to Shiga toxin and hemolytic uremic syndrome, to cholera toxin and CFTR channels, to TNF-alpha and biologic therapy in inflammatory bowel disease. Every time you hit a new GI topic in this video, ask yourself, what's the organism or insult? What structural damage does it cause? And what receptor or pathway does the treatment exploit? That habit alone will carry you through more exam questions than rote memorization ever could. The esophagus is a short organ with an outsized exam presence, and 4 conditions dominate. Squamous cell carcinoma affects the upper 2/3 and is driven by alcohol, smoking, achalasia, and chronic exposure to very hot beverages. It's the dominant esophageal cancer worldwide, especially in regions like East Asia and parts of Africa. GERD and Barrett's esophagus go together. A lower esophageal sphincter pressure below 6 millimeters of mercury lets acid reflux upward, and over time, the squamous lining can transform into intestinal-type columnar epithelium with goblet cells, visible at endoscopy as salmon pink tongues at the gastroesophageal junction. This metaplasia is the single most common pathway to esophageal adenocarcinoma, with risk climbing 30 to over 100-fold compared to the general population. Achalasia is a motility failure. Loss of inhibitory nitric oxide and VIP neurons in the myenteric plexus means the lower sphincter simply won't relax, producing the classic bird beak narrowing on barium swallow. Always consider Chagas disease as a secondary cause in the right travel history. And esophageal varices are a portal hypertension emergency. Blood rerouted from the left gastric vein into the azygous system through fragile submucosal veins that can rupture catastrophically. 4 conditions, 4 completely different mechanisms, 1 organ. Peptic ulcer disease splits cleanly into 2 patterns, and the exam loves testing the contrast. Duodenal ulcers sit in the first part of the duodenum, are driven by acid hypersecretion, carry a 90 to 95% H. pylori association, feel better with food, and carry essentially 0 cancer risk. Gastric ulcers sit on the lesser curvature, occur with normal or even reduced acid output, have a lower 70% H. pylori link, worsen with food, and absolutely must be biopsied because malignant transformation is real. A quick board pearl: posterior gastric ulcers erode into the gastroduodenal artery, causing bleeding, while anterior ulcers are more likely to perforate. Now, treatment is built entirely around 3 receptors on the parietal cell: The proton pump itself, the H plus K plus ATPase, is irreversibly blocked by PPIs like omeprazole, which must be taken 30 to 60 minutes before a meal to actually be activated in the acidic canaliculus. Long-term risks include hypomagnesemia, hip fracture, and C. difficile infection. The H2 receptor is competitively blocked by H2 antagonists, with famotidine preferred because cimetidine inhibits cytochrome P450 and has anti-androgen effects, causing gynecomastia. And the prostaglandin receptor is stimulated by misoprostol, useful for NSAID ulcer prevention, but absolutely contraindicated in pregnancy because it triggers uterine contractions. H. pylori deserves its own deep dive because it is, by volume, the single most exam-relevant organism in all of gastroenterology. It's a gram-negative, microaerophilic spiral bacillus that survives the stomach's brutal acidity through urease production, which generates a protective ammonia cloud around the bacterium while simultaneously damaging the surrounding mucosa. Its two key virulence factors, CAG-A and VAC-A, increase the risk not just of ulcers, but of gastric adenocarcinoma, and notably gastric malt lymphoma, a lymphoma that can actually regress with eradication therapy alone, a fact examiners love. For diagnosis, the urea breath test is the best non-invasive option and the test of choice to confirm eradication. Stool antigen testing and biopsy-based CLO testing are the other major tools. Treatment has gotten more nuanced as resistance has risen. First-line triple therapy is a PPI plus clarithromycin plus amoxicillin for 14 days. With penicillin allergy, swap in metronidazole for amoxicillin. In regions with high clarithromycin resistance, bismuth-based quadruple therapy, PPI, bismuth, metronidazole, and tetracycline becomes preferred. One critical exam trap, confirmatory testing must happen at least 4 weeks after treatment ends, and PPIs need to be stopped 2 weeks before testing, or you'll get a false negative. Crohn's disease and ulcerative colitis are both chronic inflammatory bowel diseases, but nearly every feature contrasts in a way that's designed to be tested. Crohn disease can strike anywhere from mouth to anus, with classic skip lesions creating a cobblestone appearance, and inflammation that's transmural, meaning it cuts through the entire bowel wall, which is exactly why fistulas and strictures are common complications. Histologically, look for non-caseating granulomas. Ulcerative colitis, in contrast, is continuous, starting at the rectum and extending proximally, confined strictly to mucosa and submucosa, with crypt abscesses on histology rather than granulomas. And because the disease stays superficial but continuous, toxic megacolon and a markedly elevated colorectal cancer risk are the feared complications instead of fistulas. Antibody testing helps separate the two. ASCA positivity favors Crohn, while antipositivity favors ulcerative colitis. Extraintestinal manifestations diverge as well. Crohn is linked to oxalate kidney stones and gallstones from bile salt malabsorption, while ulcerative colitis carries a strong, almost pathognomonic association with primary sclerosing cholangitis. And here's the twist examiners love. Smoking actually worsens Crohn disease, but is protective in ulcerative colitis, meaning smoking cessation can paradoxically trigger a UC flare. Colorectal cancer is the second leading cause of cancer death in the United States, and almost all of it follows one of two well-defined genetic roadmaps. The sporadic adenoma to carcinoma sequence begins with an APC mutation, transforming normal colon into an early adenoma, followed by a KRAS mutation pushing it into a late adenoma, then loss of chromosome 18q affecting SMAD4, driving severe dysplasia, and finally a TP53 mutation completing the transformation into invasive carcinoma. APC early, TP53 late, that order matters on exams. The hereditary pathway runs through Lynch syndrome, also called HNPCC, an autosomal dominant defect in DNA mismatch repair genes, MLH1, MSH2, MSH6, and PMS2, producing microsatellite instability, a striking predominance of right-sided colon cancers, and a sharply increased risk of endometrial and ovarian cancer in the same patients. Then there's familial adenomatous polyposis, FAP, also driven by APC mutation, but in its germline form. patients develop over 100 colonic polyps, and without prophylactic colectomy, malignant transformation is essentially guaranteed by age 40. For screening, current guidelines recommend colonoscopy starting at age 45 for average risk individuals, a relatively recent shift down from 50 that's increasingly tested. 5 hepatitis viruses, 5 completely different personalities, and the exam wants you to know each one cold. Hepatitis A spreads fecal-orally, never becomes chronic, and serology is simple. IgM means acute infection, IgG means past infection or immunity. Hepatitis B spreads through blood, sex, and vertical transmission, becoming chronic in 5 to 10% of infected adults, but a striking 90% of infected neonates. And the high-yield trap here is the window period, when HBsAg has cleared and anti-HBs hasn't yet appeared, leaving IgM anti-HBc as the only positive marker. Hepatitis C, transmitted primarily through injection drug use, becomes chronic in over 80% of cases and is a leading driver of cirrhosis and hepatocellular carcinoma. But it's now treated with direct-acting antivirals like sofosbuvir, achieving cure rates above 95%. Hepatitis D is a defective virus that can only infect in the presence of hepatitis B, and superinfection, D arriving after B is already established, is actually more dangerous than co-infection. And hepatitis E, also fecal-oral, is usually self-limited except for one critical exception. In pregnant women, especially in the 3rd trimester, mortality can reach 20%. One more rule worth remembering. Aspirin given to a child during a viral illness can trigger Rey syndrome, causing mitochondrial dysfunction, fatty liver, and encephalopathy. Cirrhosis isn't one disease process. It's a single upstream event, portal hypertension, triggering 4 distinct downstream catastrophes, and the exam tests each branch independently. Hepatic stellate cells, once activated into myofibroblasts, lay down the fibrotic bands that replace normal liver architecture and push portal pressure above 5 millimeters of mercury. From there, backward flow into the left gastric vein produces esophageal varices, managed acutely with octreotide or terlipressin and prevented long-term with propranolol. Fluid shifts produce ascites, which can become infected as spontaneous bacterial peritonitis, diagnosed when acidic fluid neutrophils exceed 250 cells per cubic millimeter, and treated with cefotaxime, with fluoroquinolones used for prophylaxis in high-risk patients. Renal vasoconstriction produces hepatorenal syndrome, recognized by a strikingly low urine sodium under 10 and rising creatinine that doesn't improve with fluids, treated with terlipressin plus albumin. And toxin bypass, blood-skipping liver detoxification through portosystemic shunts, produces hepatic encephalopathy from ammonia accumulation, causing the classic flapping tremor called asterixis, treated with lactulose to trap ammonia in the gut, plus rifaximin to reduce ammonia-producing bacteria. On top of all this sits hepatocellular carcinoma risk, marked by alpha-fetoprotein and strongly linked to alpha-toxin B1 exposure from Aspergillus flavus. It's the most common cancer arising in cirrhotic livers. Acute pancreatitis results from acinor cells digesting themselves alive. Premature activation of trypsinogen into trypsin triggers a cascade of autodigestion. Gallstones are the leading cause in women, alcohol in men, and don't forget hypertriglyceridemia above 1,000 as a less common but testable trigger. Diagnosis hinges on lipase rising more than 3 times the upper limit of normal, and hypocalcemia appears because fat saponification consumes calcium in the process. Watch for the visual triad: Gray-Turner sign in the flanks, Cullen sign around the umbilicus, and the lesser-known Fox sign along the inguinal ligament, all signs of retroperitoneal hemorrhage. Pancreatic adenocarcinoma is far more lethal, with over 60% arising in the head of the pancreas and a classic presentation of painless jaundice alongside a palpable non-tender gallbladder, Courvoisier sign, with CA 19.9 as the tumor marker. On the pharmacology side, exocrine insufficiency from chronic pancreatitis or pancreatic cancer is managed with pancrelipase, a combination of lipase, amylase, and protease taken with meals. Ursodeoxycholic acid is the only FDA-approved drug that slows progression of primary biliary cholangitis, and it can also dissolve non-calcified gallstones. And cholestyramine, a bile acid sequestrant, lowers LDL and relieves cholestatic pruritus. But be careful, it also reduces absorption of the fat-soluble vitamins A, D, E, and K. Every cause of diarrhea on the boards falls into one of 5 mechanistic buckets, and identifying the bucket almost always hands you the diagnosis. Secretory diarrhea is large volume and persists even with fasting, driven by direct activation of CFTR through cyclic AMP. Think cholera, ETEC, VIPoma, and carcinoid syndrome, and it shows a low osmotic gap, under 50. Osmotic diarrhea stops with fasting because it depends on unabsorbed solutes pulling water into the lumen. Lactase deficiency, lactulose, and magnesium salts are classic culprits, with a high osmotic gap, above 125. Inflammatory or exudative diarrhea is bloody, with fecal white cells and elevated inflammatory markers. Inflammatory bowel disease, Shigella, and ischemic colitis all live here. Malabsorptive diarrhea presents as steatorrhea with weight loss and nutritional deficiency. Celiac disease, Crohn disease, and Whipple disease are the headliners. And motility-driven diarrhea results purely from rapid transit time, seen in hyperthyroidism, diabetic autonomic neuropathy, and diarrhea-predominant irritable bowel syndrome. Learn to ask, does this stop with fasting? Is there blood? Is there fat? 3 questions that sort almost any diarrhea vignette into the right category before you even read the answer choices. E. coli alone produces 5 distinct diarrheal syndromes, depending on its toxin or invasion strategy, and this is one of the most commonly missed topics on exams. ETEC uses heat labile and heat-stable toxins to cause watery traveler's diarrhea. It's the #1 cause of that presentation worldwide. EPEC attaches to and effaces enterocytes without producing a toxin, causing non-bloody infantile diarrhea. EIEC actually invades the colonic epithelium, mimicking Shigella with bloody dysentery. EAEC forms an aggregative biofilm, causing diarrhea that persists beyond 14 days, especially in HIV patients and young children. And EHEC, the strain behind serotype 0157H7, produces Shiga-like toxin, causing bloody diarrhea that can progress to hemolytic uremic syndrome. Critically, antibiotics are contraindicated here because killing the bacteria releases more toxin and worsens HUS. Beyond E. coli, 3 parasitic triads round out the picture. Entamoeba histolytica causes bloody diarrhea plus a liver abscess filled with anchovy paste material. Giardia lamblia causes watery steatorrhea in hikers exposed to contaminated streams, identified by owl-eye trophozoites. And Cryptosporidium causes profuse watery diarrhea in HIV patients, identified by acid-fast oocysts and treated primarily by restoring CD4 counts with HART rather than antiparasitics alone. Biologic therapy transformed inflammatory bowel disease management, but anti-TNF agents come with a screening checklist that examiners test relentlessly because missing it has real patient consequences. Infliximab is a chimeric IgG1 antibody given intravenously, while adalimumab is fully human and given subcutaneously. Both neutralize TNF-alpha, the central inflammatory cytokine driving Crohn's disease and ulcerative colitis. Before starting either drug, 4 boxes must be checked. First, TB testing with a TST or interferon gamma release assay plus a chest X-ray, because anti-TNF therapy can reactivate latent tuberculosis. If positive, isoniazid prophylaxis is required before biologic initiation. Second, hepatitis B serology, since these agents can reactivate dormant HBV. Third, a heart failure assessment, because anti-TNF agents are contraindicated in patients with an ejection fraction below 35% or NYHA class 3 or 4 heart failure. Fourth, vaccination status must be current, since live vaccines become absolutely contraindicated once therapy starts. Watch also for demyelinating disease resembling multiple sclerosis and drug-induced lupus with positive ANA and anti-dsDNA. Beyond the anti-TNF class, know vedolizumab as a gut-selective anti-integrin agent with fewer systemic effects, and tofacitinib as a JAK inhibitor carrying a notable venous thromboembolism risk. Let's close with the vignette patterns that examiners reuse year after year, because recognizing the pattern instantly is worth more than any amount of isolated memorization. Painless obstructive jaundice with a palpable non-tender gallbladder is Courvoisier sign, pointing straight to pancreatic head adenocarcinoma. Flushing plus diarrhea plus bronchoconstriction plus right-sided heart murmurs describes metastatic carcinoid syndrome, treated with octreotide and confirmed with elevated urinary 5-HIAA. Diabetes, a distinctive skin rash called necrolytic migratory erythema, deep vein thrombosis, and depression, remember it as the 4 Ds, points to glucagonoma. Watery diarrhea with hypokalemia and achlorhydria, the WDHA triad, is VIPoma, also known as Werner-Morrison syndrome. An AST to ALT ratio greater than 2:1 signals alcoholic hepatitis, driven by mitochondrial damage and pyridoxine deficiency from chronic alcohol use. PAS-positive macrophages alongside diarrhea, arthritis, and dementia describes Whipple disease, caused by Trophorema whipplei. And a stomach MALT lymphoma should always make you think of H. pylori, because eradicating the organism can actually produce tumor regression without chemotherapy. Master these 7 patterns and you'll recognize a frightening number of board questions within the first sentence of the stem.